Hey everyone, it's me again to take you through your physiology component, which is ventilation, perfusion, and gaseous exchange. So let's get started. What factors affect gas diffusion? The way that I like to remember this is that we've got Fick's law, and you can remember these variables with the little mnemonic adapt. So if you have a look at the equation, it's a bit simpler to see here rather than this diagram. You've got A times D times delta P all divided by T. So it kind of looks like the word adapt. And that is what diffusion is equal to. So what do all of these variables actually mean? Well, A is the respiratory membrane area that is available for diffusion. In other words, how much surface area do you have for gases to actually travel across? So normally what happens is that the lung parenchyma itself will actually stretch so that the area increases and so that you can get more gases to diffuse across. And you've also just got a huge number of alveolar sacs that allows for that area to increase quite substantially. However, if you have conditions such as emphysema or emboli, where you've got a loss of those alveoli, then that area also decreases and therefore you will have reduced diffusion. Area as a concept is actually really self-explanatory. Less area means less diffusion. D describes the solubility of the particular gas that's diffusing in water. So generally speaking, carbon dioxide is a lot more soluble than oxygen is, but also its pressure gradient or its its need to want to go across a pressure gradient is going to be less, which means that for any given amount of gas or any given amount of water that you need for these gases to diffuse into, it'll actually be roughly equivalent because those two factors balance out. Delta P describes the pressure gradient. So a greater pressure gradient forces some of that gas to travel across, and a less pressure gradient will reduce that incentive. And T represents the thickness of the respiratory membrane. So it kind of makes sense why it's at the bottom, because the thicker the membrane, the less the diffusion is going to be. It's an inverse proportionality. So generally the epithelium is very thin. So it's 0.4 microns. And this allows for really fast diffusion. However, if you have conditions such as fibrosis, or you've got edema where you've just got fluid building up and it increases the thickness of that barrier, then you've got reduced diffusion. So what I'd encourage you to do is take each of these variables, including the ones that I've already described, and see if you can think of conditions where they might be affected, so that if you get a question in an exam, you know that X particular condition will lead to an increase or a decrease in perfusion. The other important factor is ventilation perfusion matching, which doesn't come into Fick's law, but we will discuss that a little bit later on. This diagram down here at the bottom is just to show you that some of these factors you can actually visualize quite well. So here you've got the actual alveolar duct, you've got the little alveoli coming off in the little sacs there, and you've got it leading through from the respiratory bronchioles. And then you've got the blood vessels, so the capillaries actually being there. So you will learn in histology that there is there's several layers that the oxygen has to actually go through from the airways, so from the alveoli, into the capillaries to be loaded onto blood cells. And even though I've said 0.4 microns, which is really thin, it's something that we can't even visualize. When you zoom up on it, you can see that there's 1, 2, 3, 4, 5, around like 5 or 6 layers that it needs to pass through. So any increase in the sizes of these layers, specifically the interstitium, so you've got fibrosis there, that's going to mean that diffusion is just not going to happen as effectively. Now, when it comes to the partial pressures, so these are the things that, these are the numbers that actually drive breathing. So if you didn't have differences in partial pressures, remember that everything in nature tries to go from a high concentration to a low concentration. So without these differences, things just wouldn't move at all. So that's why we need these numbers to actually be as they are. So I've put in the numbers here into a little table. By no means do you actually have to memorize these, but as a concept, it's just good to realize what some of these numbers generally can look like. So in the atmosphere, you've got your oxygen being quite high. So it's 160. This is all in millimeters of mercury. So 160 pressure. And then you've got carbon dioxide being quite low, so 0.3. When you come through to the alveoli, the atmospheric air that you're breathing in will mix with the functional reserve that's already trapped within your lungs from your previous breathing. And that functional reserve is quite rich in carbon dioxide that's been trapped. So what happens is that your oxygen pressure goes down a little bit, but your CO2 pressure comes up quite a lot. Okay, so that's what happens in the alveoli. From there, we get that diffusion process, which we talked about before, Fick's law. It goes into the arteries. What happens is that oxygen will diffuse out so that we can allow for metabolism. And if you have a look here, if you look at, so 104 to 95, remember it goes from high to low. So oxygen will really want to go down this gradient. The CO2 doesn't really change that much. So they're going to go through the arteries, through the heart, down to the systemic circulation. And in the tissues, you're going to have always going to have low oxygen because your cells are using up the oxygen for metabolism, glucose, that kind of thing. So low oxygen, which means, and that's a good thing, right? Because if I maintain low oxygen in the tissues, there's always going to be a concentration gradient that favors oxygen diffusion in the direction of the tissues, which is what we want. You also have this gradient here, right? The carbon dioxide, meaning that you will have some of the carbon dioxide going back into the vasculature to be taken away by the veins. And then, as we just mentioned, the veins themselves, you've got oxygen being about 40, carbon dioxide being about 45. And what this allows, this pressure difference means that you get oxygen moving out and you get CO2 moving in to the alveoli when it gets up here. Awesome. Now, just a couple of clinical things to keep in mind. When I'm at a high altitude, I'm mostly talking about this atmosphere bit here because that's the only thing that's changing with altitude. At a high altitude, I'm going to have decreased pressure. So you get thinning of air. That will decrease the pressure gradient because these partial pressures are proportional to the total pressure of the air, which means that if I need to go up there, I'm going to have to take really short but really deep breaths to be able to get the oxygen that I require. So classic example is if you go mountain climbing and you get mountain sickness. Low altitudes wise, you will have increased barometric pressure. So I guess low altitude, it doesn't really make sense. So something like underwater diving would be a good example. In that case, your pressure gradient will be increased quite a lot. So you need to take less frequent breaths, but they can also be deep, just to make sure that you're getting the amount of oxygen that you really require to sustain life. So how do you actually measure gas diffusion? And also which mode of measurement are you going to pick in what clinical scenario? So you've already probably heard of a couple of these indirect measurements. So these are generally less accurate. They're also a bit more convenient. So if you just need something at the bedside, they're really easy to do. The classic one is the pulse oximeter. I'm guessing we're all used to these now with COVID. It's really easy because you just have to plug it onto the fingertip as shown in this diagram here. What it's going to do is it's going to measure the percentage of hemoglobin that's bound to oxygen. And generally it should be above 94%. In specific patient groups, sometimes it's okay for it to be lower. For example, in COPD, it's okay for it to be 88 to 92. But for our purposes, 94 plus is healthy. With arterial blood gas, so ABG, it's a lot more invasive. It's a bit more complicated. You're essentially, like, it looks really uncomfortable. At least for me, when I see this, I'm thinking, oh, that would not be pleasant. You're kind of looking for the radial artery, or it can be the ulnar artery if you're having troubles. But the radial artery, insert a needle in, take a bit of blood out, so a sample. You can check at for the oxygen and CO2 levels. You can also do a bunch of other things like looking at lactates. You can look for metabolic acidosis, alkalosis. But for our purposes, we're looking at the concentrations of and pressures of oxygen. So normal readings should be about 100 for oxygen and 40 for CO2. Direct measures are much more accurate because we're actually looking into the lungs rather than at the peripheries like here, but they're also a lot less convenient. So you need to go to a specific respiratory clinic to be able to get these done. And there needs to be generally a good reason for you to do these. So the classic thing that we learn about is DLCOs, or diffusion in the lungs of carbon monoxide gas. So what happens is you have a patient, you give them a bag full of air, so normal air, but also a little bit of carbon monoxide and helium. The carbon monoxide is very good at diffusing across. So you would have heard of carbon monoxide poisoning. So it tends to diffuse really, really easily across that blood air barrier that we talked about before. But it's also it's not supposed to be in the plasma. So it's a foreign thing, which is good because you're able to measure how much actually diffused across. With helium, it's the opposite. It can't diffuse very easily across. So all of it will just stay in the lungs, regardless of how many times you breathe. So that you instruct the patient to take as many short breaths as they can. And then all you're going to do is measure the amount of gas that remains in the bag once they're done. So the classic formula that you may remember from chemistry, C1V1 equals C2V2. So C meaning concentrations, V meaning volumes, and 1 representing what you had before, 2 representing what you now have. If I calculate V2 for carbon monoxide, so whatever volume is left within the bag after they've breathed it in as much as they could, that's how much, and if you reverse calculate that, you will figure out how much diffused into the circulation. So that shows you the ability for diffusion to occur, or how good is the diffusion in their lungs. With helium, once you figure out the volume, that just tells you how much gas can fit, it can physically fit in this patient's lungs. So it tells you their total lung capacity. These are really good to be able to assess for lung health, as well as potentially diagnose some of those more niche conditions that you can't do via, for example, spirometry. Ventilation perfusion matching is what I signaled to from the first slide. It's that fifth factor that is really important for diffusion. And it's all to do with air and blood. So for efficient diffusion to occur, we need to make sure that ventilation and perfusion generally match in all parts of the lungs. And by match, I don't mean 1-to-1. So that's, while that might seem good, the actual normal should be 0.8. So if I take V, which is ventilation, divide that by Q to get perfusion, that's my ventilation perfusion ratio. That should be 0.8, which is, if you take that in terms of numbers, that'll be about 4 liters per minute of air for every 5 liters per minute of blood. If you've got VQ being less than 0.8, now we're just thinking about maths. So if we've got that number being less, we know that the numerator, so that in this case, ventilation, it is too low. So if ventilation is low, what's happening is what we call shunting. Shunting means that there is a lot more blood than can participate in gaseous diffusion, just because I don't have the air to match it. So I could have a huge amount of blood, but if I've not got enough air to actually get oxygen from, that blood's going to be basically doing nothing, right? So in what instances could I have shunting? Well, any instances where I get reduced oxygen through my airways. So for example, pneumonia, asthma, COPD. If my VQ ratio is greater than 0.8, so now this time my top number is fine, or maybe even increased, but my bottom number is what's really suffering. So that's low. So Q is perfusion, which means we've got way too low perfusion. That's what we call dead space. So it's the opposite. In this case, we've got more air than can participate in gaseous diffusion. Okay, so I could be breathing in a huge amount of oxygen, but if I don't have enough blood to carry it, what's the point, right? I'm just, it's like hitting a brick wall. Like nothing's going to get past because I don't have enough stuff to carry that oxygen through to my body. So that can include things like pulmonary embolism, where you've got something actually preventing you from taking in the correct amount of oxygen because you've got a blood clot in the arteries. Okay. However, it's really important to notice that V and Q don't have to be the same in all parts of the lungs. And there's a specific physiological reasons why that's the case. So I said 0.8, that's an average. At the base of the lungs, ventilation tends to be a little bit higher. And if you have a look at this diagram here, it explains it quite well in ways that I couldn't describe it verbally. So the reason why, if you have a look here, the apex region, you've got a lot of the weight of the lung pulling down from the apex. So all of these alveoli will be really forced to inflate, expanded out. Whereas at the bottom, the weight of everything above it pushes those alveoli and makes them a bit smaller. So because they're smaller, they have increased potential to be able to take in more oxygen. Whereas because these are so inflated, they're going to have reduced potential or compliance to take up that oxygen. That's why ventilation tends to be a lot higher in the base. Same with perfusion. Perfusion is higher in the base for the simplest reason. Because of gravity, all the blood is going to be pulled to the bottom. So ventilation and perfusion basically are going to be quite high in the base compared to the apex. However, ventilation and perfusion don't increase at the same rate. So if you have a look here, generally the perfusion tends to increase at a faster rate. So if you go from top to bottom, so right to left in this diagram, whereas ventilation tends to increase at a slightly slower rate. So VQ ratio is lower at the base. So if you think about what we said, it's going to be slightly lower at the base. If you even want to plug in some numbers, you can verify that. But it's actually closer to the optimal amount that we need. Whereas at the apex, if you look at the VQ, it's too high, which means we have a lot of dead space, a lot of reduced perfusion. So hopefully that makes sense. If you're just thinking about it really simply, remember that ventilation and perfusion increase at the base. Perfusion tends to increase at a faster rate, which means at the base, you will have a much lower ventilation perfusion ratio, but it's closer to 0.8. So having more ventilation perfusion isn't necessarily going to mean that you have a larger VQ ratio. Now, because of the fact that you're constantly breathing and things are constantly changing in your day-to-day metabolic functions, it's not going to be like that ventilation perfusion is always going to be constant at a specific part of your lung. So it's not going to be like at this point in the lung, it's always going to be 2. At this point in the lung, it's always going to be 1. It's going to keep changing. But your body is smart because it doesn't want your VQ ratio to stray too far from the normal. If it is, then you're going to get problems with shunting, dead space, and things are just going to get out of hand really, really quickly. So we need something like an automatic process to be able to make sure that the VQ ratio stays in a healthy range. And it's kind of like this constant tango just to make sure that VQ stays just right. So it's actually really simple. Like this diagram is good just to sit down with it, think about what all these arrows and all these words mean. The main concept from a broad perspective is that if perfusion is low, if blood supply to the lungs is low, your lungs are not going to be able to increase that perfusion because it's probably out of its hands. So what it will do instead is it will try and reduce ventilation to match that. And it achieves this by constricting the bronchi and bronchioles. If ventilation is low, on the other hand, the lungs, again, can't really, because it's going to be out of the hands of the lungs, probably something happening up here, it will try and decrease perfusion. And the way that works, it will try and constrict the pulmonary vessels. And again, your ventilation and perfusion will become better matched. So if you want to actually diagnose someone with a VQ mismatch, or not, it's not really a diagnosis because it's just a finding and then you have to figure out what's happened to cause it. But if you want to see if someone has a VQ mismatch based on their clinical presentation, then you can do particular scans, so VQ ratio scans, to be able to have a look at how ventilation and perfusion are going. So it might look like ventilation is very blurry and perfusion is really dark, but doesn't really mean much. So like ventilation will always look like this. The main thing you can see here is that ventilation seems to be quite good in all parts of the lungs. But then if you have a look over in perfusion, it's good in most of it. But then if you have a look at this part of the lung, a little bit of this part up here, and then this part down here, it seems that you've got reduced blood supply. So you've got poor diffusion, but seemingly okay ventilation. So if I've got good ventilation, but really low diffusion, that's going to be a concept of dead space. So one of the big red flags I'll be thinking about is there an embolism that's causing this? And of course, there'll be other things if that's not the case. All right, and that is pretty much it for this particular lecture. I hope you really enjoyed. If you do have any questions, feel free to reach out to me privately or when we have our group lessons and we're talking with you live. Best of luck for your exams, and I'll see you soon.